Hello, everybody. This is Scott here. Today, I put together something, just going to take a few minutes of your time and put together something over a topic that doesn't get talked about very much, and that is methemoglobinemia. We have the ability on the LifePak 15 to measure methemoglobin, but I don't think it gets talked about very much. So I thought I'd put together a short little talk about it, and we'll go over some stuff together and make sure that we all are catching this if it is present. So, some background really quickly. We know, the binding of oxygen is covalent. They're sharing each two electrons, so they're sharing four electrons, and that's an important aspect of methemoglobin because of the pathophysiology of what's going to happen now. Normally, we have a heme group in every hemoglobin protein molecule that exists in our red blood cells, and we have millions of those. And the iron is typically ferrous, is what we refer to whenever it is a 2 plus. So the ferrous 2 plus iron, because there's a sharing of two electrons in oxygen. If you look, at this molecule that's sharing two electrons, it's going to share the two with iron and bind very nicely, and we get oxygen molecules that want to share in each of the four heme groups in all of the hemoglobin in our blood. So this is a pretty efficient means of getting oxygen to our tissues. Now, what can happen is with methemoglobin, we get an oxidized form of the iron in the red blood cell. It goes from an Fe2 plus to an Fe3 plus. That doesn't allow for the even exchange and sharing of electrons, and so oxygen, if it's already bound to it, will stay bound, and if it's not bound, it cannot bind any longer. So it's possible that we can get this picked up by our monitors that's showing methemoglobin or SP-Met, and it's positive anything over 1%. All right. The big idea with this, the take home, the walk away information for this is if I see methemoglobin, I can't fix it without some support from the hospital because the treatments that I have on the ambulance are not going to be effective. So the treatment's very specific, not usually available. So there are a couple of different ways you can get this. Generally, it's acquired through medications that are compound substances that we take into our bodies. So it can be congenital, but I'm not going to go into that. It's a little bit complicated, but there is a possibility of a genetic mutation that will cause folks to be very susceptible to methemoglobin. So the patho is Fe2 plus is oxidized to Fe3 plus. It's not super important that you remember that ferrous is the Fe2 plus, but I refer to the ferric, and it sounds like sick. So ferric is sick. That's when they're the Fe3 plus, and they're either binding or not binding to the oxygen molecules. They're not gonna go on and off of the hemoglobin at this point. So one of the first things you might notice is a very dark color of blood, and with a lot of your patients being dehydrated, that may not really catch your eye. But um, you know, speaking about the color of the blood, if you look at this very left example over here, you see how chocolatey color. That's usually a term they use to just describe the blood. Basically, the blood has rust at this point. It's oxidized. Oxidation is rust. And so we have oxidized iron essentially. So that's why it looks this way. It should be bright as you're used to seeing it. So when we see methemoglobin, unless our monitor tells us, we've got to kind of pick up on some signs and symptoms. Your patients could, have low levels where they don't have any symptomology, but there may be some medications that are interacting and causing a low level of methemoglobin. So if you see cyanosis, that's even just a light blue slate color to their skin. This is always a possibility. You just look at the monitor and see if we've got any measuring any levels of methemoglobin greater than 1%. So cyanosis, chocolate brown blood, those are at levels above 15%, up to 30. And as it gets up to 30 to 50, we get people that are short of breath, headache, dizziness, possibly syncope. They'll start breathing faster. They've got some acidosis and potentially some arrhythmias, seizures, and anything greater than 70 is potentially deadly. All right, now the long list of potential causes for methemoglobin. It starts with the canes, and as I've understood this for the longest time, the canes have been the number one thing that I think about. So when I'm on the ambulance, if I get sent to a place where a patient is short of breath or having a cyanosis or some sort of a hypoxic problem, if you send me to a dental office, an ophthalmic surgery center where I know they're using any kind of canes, lidocaine, benzocaine, bupivacaine, anything like that, and you send me there, it's on my mind. It's not something that I'm going to think is very likely, but it's always a possibility. So this has always been for me like one of the number one causes of methemoglobin potential problems. So there's a long list of other things though that we could always kind of keep in mind. So peridium, peridium is used for the pain control and causes the orange urine and urinary tract infections. It's often prescribed right alongside the antibiotics that are given for the UTIs. So that's always a possibility. Sylvadine cream, that is given generally for burns of all different sorts of levels. Even minor burns, they may have it at home. Silver nitrate. This is a If you don't work in the hospital, you probably haven't seen a lot of silver nitrate, but you may see the evidence of that in your patients. So, getting small little skin tags removed. Silver nitrate is often used. It comes on a little stick, and it's touched to the blood, and it will prevent any bleeding from the site where we cut off the skin tag. So, silvadine or silver nitrate is used in that fashion generally to stop bleeding. Now, this infants on GERD medications. This is 4 to 6 month age infants. They are if they're on GERD medications, what this does is it doesn't let the pH get low enough in their stomach often, and the bacteria that can proliferate in that case can allow nitrate forming bacteria to exist and cause oxidation. So anti-neoplastic medications. So I'm not great at cancer drugs and knowing the names of those and their mechanisms because there's so many of them. But anybody that's on chemotherapy is a possibility for us. So go to the next page. Acetaminophen and Celebrex. Celebrex being an anti-inflammatory. I think we're all really familiar with acetaminophen, so it's just kind of the back of my mind. I haven't seen any cases of this that I know of here, but it is mentioned in the literature that I've looked at. Herbicides and insecticides, I think we always kind of stratify for that when somebody's short of breath. We look for other signs and symptoms. We're always thinking about organophosphates as well as anything else that might be causing shortness of breath or any symptom patterns. Indigo carmine. This is not a compound that is very familiar to probably most of us. It is often used to as a marker in amniotic fluid leaks. So just a little note there for that. Now, resorcinol is a chemical that is in drugs that treat eczema, psoriasis, dandruff, sunscreen, Vagisil, Clearasil. So if somebody is using a medication that is related to those, then we could look at that as maybe a potential cause, especially if it's a new medication. So Reglan or metoclopramide, that is a commonly used anti-nausea medication. So sulfa medications like Bactrim, actually Lasix has a sulfa component in it, and Septro. So what do we do if we find this? Well, for number one, we have to realize a couple of things. This is generally an assessment thing and realizing that there's a condition that we really can't treat in the field. So the biggest thing is figuring it out quickly and realizing that even our oxygen administration is probably not going to help a whole lot. Our pulse ox is going to give us false readings. And so we've got to get moving. So rapid transport to the hospital, high flow to. One of the things that might help us is to realize if we've had low sats in a patient, if it does say low sats, it may be false, but also giving them oxygen, not bringing those sats up with the blue skin, and adding in a positive causative factor. You got to put all that together to come up with this, plus some hemoglobin showing up in a high percentage on our monitor lets us know that we've got to let the hospital know. We got a potential methemoglobin patient so that they can get a hold of their pharmacy because the treatment for this is very specific. That treatment is methylene blue, and that'll be something that most of your hospitals carry. It's not an expensive medication from what I understand, and we've got to get that up to our patient and start administering that. If that's not going to be effective, or we're so far that we have to do an exchange transfusion and get the patient some blood that is not oxidized, that's a possibility, and also hyperbaric oxygen along with IV hydration and bicarbonate if they have metabolic acidosis. So That brings us to the back end of this. Recognize the skin color. Look for cyanosis. It doesn't respond to oxygen. If their blood looks dark and chocolatey, along with the methemoglobin is greater than 1%. So, and obviously, as the percentage goes up, our symptomology is probably going to get more severe. So, headache, dizziness, weakness, confusion, syncope, and dysrhythmias, and seizures, all of those things relate to hypoxic tissue level problems. So we're not able to oxygenate our tissues, and all those symptoms can be related to hypoxia. So we want to transport emergency. We don't want to be in the field any longer than we have to because we can't fix this definitively in the field. That's the big idea. So notify the ER immediately. Give them as much time as you possibly can to let them know that you're on the way and let them know what you found with your assessment.